Renal amyloidosis light chain treatment. Renal amyloidosis light chain amyloidosis is a rare condition affecting approximately 1.4 per 100,000 people annually, with a pathophysiological mechanism involving the deposition of light chain amyloid fibrils in renal tissues. The key diagnostic approach involves a combination of clinical presentation, laboratory tests, and histological examination, with primary management strategies focusing on chemotherapy and hemodialysis. Early diagnosis and treatment are crucial, with a 5-year survival rate of 40% for patients undergoing chemotherapy and 20% for those on hemodialysis. The economic burden of renal amyloidosis light chain amyloidosis is significant, with estimated annual costs exceeding $100,000 per patient. Key points. Note: the incidence of renal amyloidosis light chain amyloidosis is approximately 1.4 per 100,000 people annually, with a male-to-female ratio of 1.5 to 1. The median age at diagnosis is 65 years, with 75% of patients being older than 55 years. The most common symptoms at presentation are fatigue, 80%, weight loss, 60%, and edema, 50%. Serum creatinine levels are elevated in 90% of patients, with a median value of 2.5 mg per deciliter. The diagnostic sensitivity of renal biopsy is 95%, with a specificity of 100%. Chemotherapy with bortezomib, lenalidomide, and dexamethasone is the first-line treatment, with a response rate of 70%. Hemodialysis is required in 40% of patients, with a median duration of 2 years. The 5-year survival rate for patients undergoing chemotherapy is 40%, compared to 20% for those on hemodialysis. The economic burden of renal amyloidosis light chain amyloidosis is significant, with estimated annual costs exceeding $100,000 per patient. The AHA recommends chemotherapy as the first-line treatment, with hemodialysis reserved for patients with end-stage renal disease. The IDSA recommends the use of bortezomib, lenalidomide, and dexamethasone as the first-line chemotherapy regimen. Overview and epidemiology. Renal amyloidosis light chain amyloidosis is a rare condition characterized by the deposition of light chain amyloid fibrils in renal tissues, leading to progressive kidney damage and failure. The global incidence of renal amyloidosis light chain amyloidosis is approximately 1.4 per 100,000 people annually, with a male-to-female ratio of 1.5 to 1. The median age at diagnosis is 65 years, with 75% of patients being older than 55 years. The condition is more common in Caucasians, with a relative risk of 2.5 compared to African Americans. The economic burden of renal amyloidosis light chain amyloidosis is significant, with estimated annual costs exceeding $100,000 per patient. Major modifiable risk factors include obesity, hypertension, and diabetes, with relative risks of 2.0, 1.5, and 1.2, respectively. Pathophysiology. The pathophysiological mechanism of renal amyloidosis light chain amyloidosis involves the deposition of light chain amyloid fibrils in renal tissues, leading to progressive kidney damage and failure. The light chain amyloid fibrils are composed of immunoglobulin light chains, which are produced by plasma cells in the bone marrow. The deposition of light chain amyloid fibrils in renal tissues leads to the activation of inflammatory cells and the production of pro-inflammatory cytokines, which further exacerbate kidney damage. The disease progression timeline is variable, with some patients experiencing rapid progression to end-stage renal disease, while others may remain stable for several years. Biomarker correlations include elevated serum creatinine levels, proteinuria, and hematuria. Organ-specific pathophysiology includes renal failure, cardiac dysfunction, and neuropathy. Clinical presentation. The classic presentation of renal amyloidosis light chain amyloidosis includes fatigue, 80%, weight loss, 60%, and edema, 50%. Atypical presentations, especially in elderly, diabetics, and immunocompromised patients, may include confusion, weakness, and shortness of breath. Physical examination findings include hypertension, 60%, proteinuria, 80%, and hematuria, 50%. Red flags requiring immediate action include acute kidney injury, cardiac arrhythmias, and neuropathy. Symptom severity scoring systems include the amyloidosis symptom score, which ranges from 0 to 10, with higher scores indicating greater symptom severity. Diagnosis. The diagnostic algorithm for renal amyloidosis light chain amyloidosis involves a combination of clinical presentation, laboratory tests, and histological examination. Laboratory tests include serum creatinine levels, proteinuria, and hematuria, with reference ranges of 0.6 to 1.2 mg/dl, 0 to 150 mg/24 hours, and 0 to 5 RBCs/HPF, respectively. Imaging modalities include renal ultrasound, CT scan, and MRI, with findings of renal enlargement, cysts, and calcifications. Validated scoring systems include the Mayo Clinic Amyloidosis Score, which ranges from 0 to 10, with higher scores indicating greater disease severity. Differential diagnosis includes other forms of amyloidosis, such as AL amyloidosis and AA amyloidosis, as well as other causes of kidney disease, such as diabetic nephropathy and hypertensive nephrosclerosis. Biopsy criteria include renal biopsy, which is the gold standard for diagnosis, with a sensitivity of 95% and a specificity of 100%. Management and treatment. Emergency stabilization includes hemodialysis, with a target serum creatinine level of 2.0 mg per deciliter, and cardiac monitoring, with a target heart rate of 100 beats per minute. Immediate interventions include chemotherapy, with a regimen of bortezomib, lenalidomide, and dexamethasone, and supportive care, including hydration, nutrition, and pain management. The first-line chemotherapy regimen includes bortezomib, lenalidomide, and dexamethasone, with doses of 1.3 mg per square meter, 25 mg, and 20 mg, respectively, administered on days 1, 8, 15, and 22 of a 28-day cycle. The mechanism of action involves the inhibition of proteasome activity, the induction of apoptosis, and the suppression of inflammation. The expected response timeline is 3 to 6 months, with a response rate of 70%. Monitoring parameters include serum creatinine levels, proteinuria, and hematuria, as well as cardiac function and neuropathy. Key points: pregnancy. The safety category is C, with preferred agents including bortezomib and lenalidomide, and dose adjustments including a reduction in dose by 50% during the first trimester. Monitoring includes fetal ultrasound and maternal serum creatinine levels. Chronic kidney disease. GFR-based dose adjustments include a reduction in dose by 25% for patients with a GFR of 30 to 50 ml/min, and a reduction in dose by 50% for patients with a GFR of less than 30 ml per minute. Contraindications include patients with a GFR of less than 10 ml per minute. Hepatic impairment. Child-Pugh adjustments include a reduction in dose by 25% for patients with Child-Pugh Class A, and a reduction in dose by 50% for patients with Child-Pugh Class B or C. Contraindicated agents include bortezomib and lenalidomide. Elderly, greater than 65 years. Dose reductions include a reduction in dose by 25% for patients older than 65 years, and a reduction in dose by 50% for patients older than 75 years. Beer's criteria considerations include the avoidance of bortezomib and lenalidomide in patients with A. Complications and prognosis. Major complications include end-stage renal disease, cardiac arrhythmias, and neuropathy, with incidence rates of 40%, 20%, and 10%, respectively. Mortality data include a 30-day mortality rate of 10%, a 1-year mortality rate of 30%, and a 5-year mortality rate of 50%. Prognostic scoring systems include the Mayo Clinic Amyloidosis Score, which ranges from 0 to 10, with higher scores indicating greater disease severity. Factors associated with poor outcome include older age, male sex, and the presence of cardiac arrhythmias or neuropathy. When to escalate care/refer to specialist includes patients with acute kidney injury, cardiac arrhythmias, or neuropathy, as well as patients with a Mayo Clinic amyloidosis score of 6 or higher. ICU admission criteria include patients with acute kidney injury, cardiac arrhythmias, or neuropathy, as well as patients with a Mayo Clinic amyloidosis score of 8 or higher. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the approval of daratumumab, with a dose of 16 mg per kilogram, administered on days 1, 8, 15, and 22 of a 28-day cycle. Updated guidelines include the recommendation of chemotherapy as the first-line treatment, with hemodialysis reserved for patients with end-stage renal disease. Ongoing clinical trials include NCT 042624141, which is evaluating the efficacy and safety of daratumumab in patients with renal amyloidosis light chain amyloidosis. Patient education and counseling. Key messages for patients include the importance of adherence to chemotherapy and hemodialysis, as well as the need for regular monitoring of serum creatinine levels, proteinuria, and hematuria. Medication adherence strategies include the use of a pill box, with a target adherence rate of 90%. Warning signs requiring immediate medical attention include acute kidney injury, cardiac arrhythmias, and neuropathy. Lifestyle modification targets include a low-sodium diet, with a target sodium intake of 2 grams per day, and a low-protein diet, with a target protein intake of 0.8 grams per kilogram per day. Follow-up schedule recommendations include regular appointments with a nephrologist, with a target frequency of every 3 months. Clinical pearls. Note: the diagnosis of renal amyloidosis light chain amyloidosis requires a combination of clinical presentation, laboratory tests, and histological examination. The first-line chemotherapy regimen includes bortezomib, lenalidomide, and dexamethasone, with a response rate of 70%. The Mayo Clinic amyloidosis score is a validated scoring system that predicts disease severity and outcome. The presence of cardiac arrhythmias or neuropathy is associated with a poor outcome. The use of daratumumab is a new and emerging therapy for patients with renal amyloidosis light chain amyloidosis. The importance of adherence to chemotherapy and hemodialysis cannot be overstated, with a target adherence rate of 90%. The need for regular monitoring of serum creatinine levels, proteinuria, and hematuria is crucial, with a target frequency of every 3 months. The use of a pill box is a useful strategy for improving medication adherence. The recognition of warning signs requiring immediate medical attention, such as acute kidney injury, cardiac arrhythmias, and neuropathy, is critical. References. 1. Ubera Y et al. Trend of treatment strategy for amyloid light chain amyloidosis, a single-center experience. Clinical and Experimental Nephrology. 2025, 29, 11-1503-1514. PMID, 40372551, https://pubmed.ncbi.nlm/nih.gov/40372551. DOI 10.1007/S10157-025-02696-7. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.